All right. Good morning, everyone. Please allow me to welcome you. And we have Dr. Phillip Chang, who is an assistant professor in cancer rehabilitation medicine at the Samuel Olson Comprehensive Cancer Center at Cedars-Sinai Medical Center. He completed his residency in physical medicine and rehabilitation at SUNY Downstate, followed by a fellowship in hospice and palliative care at, I'm sorry, I can't pronounce that one, Montefiore, a fellowship in cancer rehabilitation at the University of Michigan. He has published on various topics in cancer rehabilitation and works with the Cancer Rehabilitation Physician Consortium of America Academy of Physical Medicine and Rehabilitation. Thank you so much and welcome, Dr. Chang.
Yeah, thank you so much, Pastor Rhonda, for inviting me, and thank you everyone for joining this morning. Yeah, I think we can feel free to kind of keep this more casual and conversational. Or if that's okay, Pastor Rhonda. So if anybody has questions, feel free to chime in and ask, or otherwise you could maybe enter questions in the chat, and we could talk about them afterwards. But basically, I just wanted to kind of give a general overview of a couple topics that frequently come up in cancer survivorship. And these topics are pain and fatigue. So we'll be going into both of these today. So I do not have any disclosures. And the first of these two subjects that I want to discuss is pain. I think it's important to understand, kind of how pain works, as well as the types of pain, before talking about the different kinds of treatment that are available. And in general, there are three kinds of pain, or rather, three mechanisms by which pain can occur. And these are nociceptive pain, or pain that occurs through the activation of pain receptors. The second kind of pain is neuropathic pain. And neuropathic pain is the kind of pain that will occur when you have some kind of damage or insult to the nervous system and our nerves in the nervous system. And finally, we have a third mechanism of pain, and this is called nociplastic pain. And this is a newer mechanism of pain, and it was actually just recently formally recognized and defined by the International Association for the Study of Pain in 2017. And as you can see, I have a couple arrows pointing from nociplastic pain to nociceptive pain and neuropathic pain. And the reason for that is because nociplastic pain is really a change in the way that pain is perceived or modulated. So having nociplastic pain can kind of affect and modulate the way that we experience nociceptive pain through pain receptors, and neuropathic pain being pain from damage to the nervous system. So just to go a little bit more in depth on these different kinds of pain. So nociceptive pain is kind of the regular everyday pain that we might have when, anything unfortunate happens. So, if you like cut your hand or you get like a paper cut or something, that'll activate pain receptors in your hand. And then those pain receptors will send pain signals up the nerves to your spinal cord. And then once it's in your spinal cord, the pain signals continue to go up other nerves, and then they connect to even more nerves in the brain. And then from there, the pain signals go to a bunch of different parts of the brain, and that essentially results in the sensation or the experience of having pain. And pain receptors are in all sorts of areas. So, they're not just in our skin, but they can be in our muscles and in our bones and our organs. So if you have like a stomach ulcer, that can activate pain receptors. And again, they'll send signals, pain signals up your nerves, up your spinal cord to your brain, then experience pain. And similarly, if you have like a broken bone, you can that will then again activate pain receptors, sending the pain signals up the spinal cord to the brain, and then we feel pain. So this is again kind of the general nociceptive pain that occurs through activation of these specific pain receptors that we call nociceptors. Now, the second kind of pain is neuropathic pain. And again, this is pain that's caused by damage to nerves. So, we have nerves kind of all throughout our body. And these nerves give us sensation. They allow us to, feel things like hot and cold or sharp or light pressures. And they also give us motor function. So they give our muscles the ability to move so we can be functional. And these nerves can be damaged. And in people going through a cancer diagnosis, there are multiple different things that can be causing damage to nerves. So, for instance, if you have a tumor that is in close proximity to a nerve to the point where it's like pressing on it. So, for instance, somebody with like a spinal cord tumor, it could be pressing either on the spinal cord or some of the nerves coming out of the spinal cord. That can then cause pain in the distribution of whatever nerves are supplying that area of skin. So, for instance, if you have a nerve or if you have like a tumor, like in the neck area, there's a bunch of nerves that are in that area that can kind of go down the arm and hand. So, for some people who have tumors kind of in the neck area, it's not uncommon for them to feel pain, nerve pain or neuropathic pain going down their arm or hand. Another thing that can commonly cause pain or nerve pain in people going through chemotherapy treatments is what we call chemotherapy neuropathy. So there are some chemotherapeutic agents, not all chemotherapeutic agents, but some that can cause damage to nerves. And the most common damage really occurs at the levels of kind of the hands and the feet. And really the first areas that tend to be affected are the fingertips and like the toes. And this kind of pain is very often characterized as being like a burning sensation or a tingling sensation or a sharp sensation. But that's another kind of nerve pain that can occur for survivors going through chemotherapeutic treatments. And finally, the last kind of pain, again, that I want to talk about is nociplastic pain. So again, this is kind of a newer term, a lesser used term. And some people may be familiar with the older term that we use, and the kind of older terms are centrally sensitized pain or central sensitization of pain. And they're both basically kind of getting at the same thing. So when we say centralization of pain or centrally sensitized pain, we're basically talking about the fact that there are kind of changes or alterations at the level of the brain, really, which is we call the brain and the spinal cord, the central nervous system. And those changes at the level of the brain and spinal cord or the central nervous system is what is more responsible for this nociplastic pain. So people experiencing more nociplastic pain, they may feel pain in a variety of different areas throughout their body. And this is kind of the kind of pain where you might go to the doctor and they might run a bunch of blood tests and they might get a bunch of different scans like x-rays or MRIs or CT scans, and they might not find anything there, and they'll say kind of everything looks okay there, but yet people still have pain. And again, it's because pain is ultimately perceived at the level of the brain. So even if everything is okay in your muscles and your joints and the hands and the knees, because of these changes at the level of the brain, pain can still occur. So basically, nociplastic pain is a type of pain that occurs when the nervous system processes pain signals abnormally. So one of the ways to think about this is like we have a guitar. So we have a guitar and we play the strings on the guitar. And when we play the strings on the guitar, it will emit a certain volume of sound. Now, when we hook up the guitar to an amplifier and we turn the volume on the amplifier way high, we can play the guitar strings with the same intensity. So we're not playing the guitar strings any harder. We're playing them at the same intensity, but because it's hooked up to the amplifier, the pain or the volume that comes out of the guitar is much higher, even though we're just playing it at the same level. And that's really what's happening with nociplastic pain. There is kind of a change at the level of the brain where the volume for pain is turned way high. So certain things that may not be painful, kind of like a light pressure to like the back area or like to the arms or legs, most people would not find that painful. But for people that have that are experiencing a higher level of nociplastic pain, the because the volume is so high, when you just do a light pressure, the pain that the sensory signals go to the brain, and then the brain just turns that signal way up, and then it feels painful, even though it really shouldn't be. So those are the three types of pain mechanisms that there are. Now, when we talk about pain in cancer, we can kind of divide it into three different kinds of pain. So the first category would be non-cancer related pain. The second would be treatment related pain. And the third would be cancer related pain or direct cancer related pain. So non-cancer related pains are, kind of all the things that may happen not related to your cancer. So for instance, if you have arthritis in your hip joint, that'll cause pain. It's not from the cancer, but you'll have pain from it, or you can have pain from it. You can have muscle pain if you just strained a muscle, or you were exercising too hard, or maybe you're just doing kind of too many household chores at home. You can sometimes develop muscle pain. Again, not related to the cancer, but it's there. Or, again, if you cut your finger or stub your finger, that'll hurt, it'll cause pain, but it's not related to the cancer. So the second category of treatment related pain will, again, include things like chemotherapy and neuropathy, which can oftentimes affect the feet and the toes. It may also include things like radiation fibrosis, which we'll be discussing later. But sometimes as a result of radiation therapy, it can cause muscle tightness and muscle hardening, which can cause pain. So again, it's not directly because these kinds of pain or discomfort are not because of the cancer itself directly, but more so because of the treatments that we give for the cancer. And then finally, cancer-related pain is going to be something that's kind of directly caused by having the cancer or by the tumors kind of themselves. So if the tumor is activating pain receptors, or again, if the tumor is kind of pressing on an area of nerves, that is something that we refer to as cancer-related pain. Okay, now for cancer-related pain, we can kind of further subdivide that into indirect causes and direct causes of pain. So, for some people that have cancer, they may be more, they may have a weaker immune system, so they may be more prone to develop infection, or they, depending on where the cancer is, they may be more prone to developing swelling that we can sometimes call lymphedema. If it's caused by a blockage of lymph nodes or the lymphatic system. So, these would be indirect causes of cancer-related pain. And then, we would say that the direct causes, again, are mediated more by tumors themselves directly. And that can either be nociceptive. So again, the tumors directly kind of activating pain receptors in the body, whether it be in the skin or muscles or organs, or neuropathic pain because the tumor is pressing on an area of nerves. So, why is pain type important and why am I talking about all this? One of the reasons is because sometimes the treatments for these different kinds of pains overlap, but a lot of times they don't. So we want to, have a good idea of what is causing the pain and what kind of pain someone is experiencing because those things may have a more specific treatment. So, for nociceptive pain, may want to use nociceptive specific treatments. And for neuropathic pain, we may want to use neuropathic specific treatments. And for nociplastic pain, we may want to use nociplastic specific treatments. Again, there's going to be some overlap in terms of the different therapies between nociceptive, neuropathic, and nociplastic pains, but there are times where you have to kind of treat them differently with different kinds of interventions. And just kind of an example of this is in people who maybe have a history of breast cancer and undergo treatment for breast cancer, and sometimes pain can occur after that. So sometimes we see, somebody has breast surgery and then they can develop pain immediately following breast surgery, and maybe that pain is related to the incisions that were created. Maybe they have a complication of infection. Maybe they had a mastectomy and they developed phantom breast pains and sensations. And then maybe this doesn't happen to most people, but in some people, the pain can kind of linger. And at that point, we may call it chronic pain. And at that point, there may be a lot of different causes of that pain. So again, we want to be as specific in kind of targeting what the specific cause of that pain will be, so we can give it a very specific treatment. Okay, I'm seeing a question here from Sharon in the chat. She's asking, can treatment-related pain develop many years after treatment, i.e. pain in the neck due to radiation treatment? So the answer to that question is yes. We will be briefly discussing radiation fibrosis is what I think she is referring to. But yeah, the answer to that question is yes. Not for most situations, but really I would say radiation is kind of a unique situation which that can occur. Okay, so moving on, I just want to discuss a few specific examples of pain that can occur in people dealing with a cancer diagnosis and going through cancer treatment. And we'll start with chemotherapy-induced neuropathy. So again, this is kind of neuropathic or nerve pain, commonly affecting the hands and the feet, although sometimes patients can feel it kind of going upwards in the arms and upwards in the legs. And this most commonly occurs with people who are receiving platinum-based chemotherapy or Taxol chemotherapies or vinca alkaloids. In the case of people who may be dealing with a leukemia or lymphoma diagnosis. And this kind of pain is characterized by burning and tingling for patients who might be receiving therapy with oxaliplatin. For instance, for people with like colon cancers, a lot of times the pain might be worse if it's cold. So it's not uncommon if you're like not wearing socks and you're touched like a cold floor to your foot, that can cause pain. And then a lot of people also have numbness in these areas as well. And then other things we can see as a result of the nerve damage, or some people may have difficulty walking, some people may have poor balance, and some people may also have increased difficulty using their hands, specifically for tasks that require more fine motor coordination, such as knitting or typing or texting. And I'm seeing another question here. The question is there any relation to hearing loss or tingling, ringing in the ear canal too? Okay, I think you asked this question in regards to chemotherapy neuropathy. So yes, there is, specifically for, I believe again, so this might be a better question for oncologists. But I believe with some platinum-based chemotherapeutic agents, it can cause basically like a loss of hearing, and some people may develop a ringing in the ears. As far as I know, yes, but don't quote me on that. And that might be a better question for an ear, nose, and throat doctor or an oncologist. Okay, moving on here. Okay, so what are the different kinds of treatments that we can do for neuropathic or nerve-related pain? And there's a lot. So these are basically guidelines from different pain societies for how to treat or the best ways or best medications for treatment of neuropathic pain. So these are Canadian Pain Society guidelines. I think these ones are from Australia. This is from Japan. These are kind of American guidelines. And as you can see, they kind of have different recommended first line, second line, third line agents for treating neuropathic pain. And they are mostly the same as each other. So you may have heard of the medication gabapentin, which is a specific kind of gabapentinoid. And that's a really, really common medication that we kind of use as first line to treat neuropathic pain. Another common first line of agents are called tricyclic antidepressants. Tricyclic antidepressants, and examples of that would be like amitriptyline or nortriptyline. And SNRI stands for serotonin and norepinephrine reuptake inhibitors. And probably the most common ones that we use are Effexor and Cymbalta, or trade name is duloxetine. And in particular, I would say duloxetine is one that we use quite a bit because specifically for chemotherapy-induced neuropathy, there are some guidelines from the American Society of Clinical Oncology in 2020 that basically stated that this medication, duloxetine, is the only one out of all these that really has enough evidence to give a recommendation for using. So I would say this is the most common one. One thing I'll say is that if you're on tamoxifen, for breast cancer, this is not a medication that you should be using, as there can be some interactions with tamoxifen. Okay, I'm seeing some other questions. So I see a question of, are there exercises you can suggest to help relieve pain in muscles and joints? Yes. So I would say it depends though on what kind of muscle and joint pain you're having. So for instance, let's say, you're having muscle pain because of like leg cramps or something like that. Then you just want to stretch. Let's say you're having joint pain because of knee arthritis or hip arthritis, and there are very specific strengthening exercises that you would want to do, basically strengthening the muscles surrounding the joint. So I would say sometimes yes, but it depends on the situation. And then, yeah, if you're kind of more talking about muscle and joint pains that occur in the setting of people undergoing like chemotherapy, it's not uncommon that after infusions, people report muscle aches and kind of joint pains. I generally don't advise my patients to do exercise during those times. Yeah, it really depends. Like sometimes they're dehydrated and I tell them to drink more water, or sometimes we might try like a magnesium supplement. Sometimes, might advise Tylenol, or sometimes, we might advise something stronger. So I would say it really depends on the specific situations, but in some situations, definitely specific kinds of exercises can be helpful. Okay, another question. Neuropathy that seems to be spreading 5 years after cancer treatment in the feet. Okay. So I think maybe this is in relation to the question of if treatment-related pains can develop later. I'll say this. In general, chemotherapy-related neuropathy should not be causing worsened pain after you finish treatment. Now, there are a few exceptions to that. Those exceptions, again, are in people who have received platinum-based chemotherapies, and that's because there's something called the coasting phenomenon, in which symptoms can either start or worsen after you finish treatment, but that's generally doesn't occur after a year. So if it's 5 years later and you feel like something is worsening, I would advise that you follow up with your um, physician, your primary care physician, because there are other causes of this kind of similar neuropathy, like in the hands and feet, that can be caused by things other than chemotherapy. The most common ones are like diabetes, typically, or like sometimes you can have like a vitamin deficiency, like a B12 deficiency. Um, but I would say, yeah, I would recommend someone in that situation to follow up with their primary care doctor, to be evaluated for potential other causes of neuropathy. Okay, and another question. Many times patients mention that they are scared of taking prescription drugs for pain because they think all of them are addictive. Are all the pain drugs addictive? So the short answer to that question is no. Now, the primary type of pain medication that is addictive that we kind of have been constantly hearing about in the news for the past several years now are opioids. So these are opioids. And again, opioids, you can see them. They are in the some of the pain guidelines here, as second and third line agents. So these are addictive, and these are the ones that we should definitely be cautious when using. That doesn't mean that we should never use them, and that doesn't mean that there aren't really, really good situations where they can't be very helpful, because there are a lot of times opioids can be very, very helpful. But whenever these are taken or used, they do have to be used under the guidance of a skilled and experienced physician, so that it's taken in an appropriate manner. And whenever the dose is reduced or decreased, that should also happen under the guidance of a specialized clinician. Um, that said, a lot of these other pain medications are not addictive. So you think about medications like over the counter, like Tylenol or Advil or Aleve. Those medications are not addictive. That said, not all medications are safe just because they're not addictive. They can have other side effects. For example, if you have kidney issues, medications like ibuprofen, Advil, and Aleve can do damage to the kidneys. So that's something we have to be cautious of in certain situations. If you have like liver issues, then we have to be cautious of the amount of Tylenol that you're taking. So definitely we have to be cautious in certain situations, but not all medications are addictive. Gabapentin typically is not thought to be addictive. These tricyclic antidepressants are not thought to be addictive, and serotonin norepinephrine reuptake inhibitors are not thought to be addictive. That said, addiction is a very specific thing. Addiction, it's not, addiction is different than tolerance. So tolerance is basically the fact that your body will need more of a specific medication to get kind of the same effect, because your body kind of grows used to it. So that's tolerance. And that's kind of related to dependence, where your body can become physically dependent on a medication like an opioid medication, meaning that, if you stop taking it, you can go through like withdrawal. But that is different from addiction. We shouldn't confuse that with addiction. Addiction is characterized by compulsive use, and it's characterized by kind of like abusing a medication. It's characterized by really kind of social dysfunction. And again, I'm not an addiction specialist, so don't quote me on these things. But it's really characterized by a habit of misuse, to the point where you may be becoming like dysfunctional socially, because you are so because someone is so kind of almost obsessed with getting more medication, using these types of medication. So I would say, there's just a difference between addiction and tolerance and dependence. And I point that out because, for instance, with medications like duloxetine, in medications like gabapentin, you can't stop those cold turkey. You do have to be weaned down. And medications like duloxetine in particular, if you stop it cold turkey, you can go through like a kind of withdrawal. So But again, that's not necessarily related to addiction. So sorry that that was kind of a long-winded answer there. Um, okay, so the next kind of example of pain I want to talk about is post-mastectomy pain, or sometimes called post-mastectomy pain syndrome. And this is a kind of pain that can occur in people who have undergone breast surgery, typically a lumpectomy or an axillary lymph node dissection or a mastectomy. And there are a lot of different, um, there are many different ways in which this kind of pain can present, but I would say one of the common ways is through damage of this specific nerve called the intercostobrachial nerve. And this nerve kind of subserves this area of skin shown in green. So it's really common for patients to get nerve or neuropathic pain in this area. So they'll have, again, burning, tingling, numbness, and sharp pains. So, one of the things that we can do for this is topicals, for some people can be really helpful in kind of providing short-term relief. And there's a lot of different kinds of topicals we can use. One of the common ones I just recommend is just over-the-counter like lidocaine. If that's not helpful, some people can try menthol-based topicals. That's generally going to be anything that smells like minty. There are CBD and THC-based topicals that you can get sometimes over the counter in recreational dispensaries. I would be careful of using these for nerve pain. I have had a few patients tell me before that sometimes this causes worsened pain and burning. So what I typically advise is that somebody uses like a really small amount, like maybe the area of like, a nickel or a dime, just to make sure it's not worsening pain. And then if they find that it's helpful, then they can use it on a larger area. For patients that have like radiation changes like on their skin and they feel kind of more tightness, this is something I've been recommending more recently. It's called the latest skin food, and I've had multiple patients tell me that they thought that this was helpful. You can get this from Amazon. I've also been told that it's sold in Whole Foods. There are specialized compound creams. So a compound cream is a special customized kind of topical medication that is made specially in a compounding pharmacy. And we can basically have the pharmacist put in a lot of different kinds of medications. So they can put in like nerve pain medications like gabapentin. They can put in like opioid kind of medications like ketamine. And they can add numbing medications like lidocaine. So they kind of mix it all together. And some people can get relief from these kinds of creams too. They are more expensive, depending on what you put in. And for a compound cream, you may expect to pay like between $100 and $150 for like a month-long supply. But for some people, this can be helpful. And there are things like capsaicin also. So capsaicin is basically a type of topical that is derived from spicy peppers. And essentially what this does is it kind of stimulates the area so much so, and stimulates all the nerve receptors so much so that they kind of become desensitized. So for some people with post-mastectomy pain syndrome, these kinds of creams can be helpful. Again, I wouldn't, you can try these things, but again, I would follow I would do this at the discretion of like a physician. Okay. And then finally for post-mastectomy pain, there are also some injections that can be done for patients who do have pain in that distribution of the intercostobrachial nerve, which we often see damage in patients undergoing axillary lymph node dissections. We can do injections here to kind of block the pain signals from the nerve, and that can be helpful for some people. Okay. The third example that I want to go through is frozen shoulder. And kind of the medical term that we use is adhesive capsulitis. So this is something that can that we think at least can occur with higher frequency in people who undergo treatment for breast cancer specifically. And in this kind of syndrome, basically the shoulder becomes really difficult to move. It can become really, really painful, especially kind of in the initial months that it occurs. And then, a lot of the treatments that we do for this are really physical therapy based. So it's a lot of movement and trying to get range of motion back. And then for pain, a lot of times we give anti-inflammatory medications. And these kinds of injections, where we kind of inject steroids straight into the shoulder joint, can actually be quite helpful in relieving pain. Okay, so I think Sharon had asked about radiation before. So our next example is radiation fibrosis. And this is defined as a progressive tissue hardening and dysfunction that occurs in response to radiation. And a lot of times, basically, so when you get radiation, unfortunately, they're not able to only target the tumor, but all the superficial structures that are kind of in front of the tumor also receive radiation. And when they do, you can kind of get like scar tissue deposition in those tissues, and it can lead to hardening. So, for example, in somebody who may have undergone radiation to their neck, they may experiencing really stiff and hard muscles, and patients will often, the first thing they'll often complain of is kind of like a feeling of increased tightness. A lot of times this can lead to muscle pains. And we kind of break down the timeline of when these kinds of effects can occur as acute, and acute effects will occur kind of during or immediately after treatment. And then early delayed would be anytime up to 3 months after completion of treatment, and late delayed effects will be occurring more than 3 months after completion of treatment. And again, this doesn't happen to most people. Most people are totally fine. But for some people, this may occur. It's not uncommon. Again, I kind of see, the worst cases. But it's not uncommon in my clinic because, again, I kind of get the worst cases that somebody may come to me like years later, 5 years later, 10 years later after finishing the radiation treatment, and they may just be starting to get tightness then. To revisit the former question, yes, you can sometimes get changes years down the line, but as far as I know and can think of, it's really radiation is the only example that I can think of where that I know of, at least to my knowledge, that occurs. Okay, so we have a few treatment principles of how to deal with this, and really it's about stretching what's tight. So we'll take an example of somebody who had radiation to like their chest wall area. So when you get radiation to the anterior, the front chest wall, kind of in the breast area for somebody with breast cancer, you can get tightness of the chest. So you want to stretch the chest. You want to strengthen what's being overstretched. That would be like all the back muscles. You want to strengthen all the back muscles. We can consider the use of braces to help us adopt a better posture. So this is an example of like a figure of 8 brace. There are different medications we can use, like muscle relaxers, which can sometimes be helpful for the muscle-related pains. And then there are certain injections we can do called trigger point injections, where we essentially try to use the needle, or we use a needle to kind of poke the muscle a few times to get the muscle to relax. And sometimes we can use a medication called botulinum toxin, which you may know better as Botox, which is a brand name, but the generic is just botulinum toxin. And this can also help muscles to relax in certain situations. Okay, I see another question or comment. So if the tightness occurred early but still continues, is it too late for treatment? I would argue that it's never too late for treatment for these kinds of issues, especially for like muscle pains. There's always something else you could do. So no, I would say it's not too late for treatment, and you should still stretch, and you should still try to kind of follow these different principles to help mediate the pain. So it's better if you do it earlier for sure. But wherever you are at whatever time, I would say there's always something you can at least try. Okay. And then finally, for pain that is considered to be, again, directly kind of cancer related or directly kind of coming from a tumor, it's needed, and kind of these first line things like Tylenol, Advil aren't working. There are kind of, again, the opioid medications, and these can be addictive, but again, when given in a supervised setting, they are really, really safe in many situations. So these are a lot of the commonly used opioids for people experiencing cancer related pain, and they can be really, really effective. So I would just want to say that, pain is something that can usually be controlled. And I just want to say that there's a lot of different things that I haven't talked about here that can be tried for pain. So, there's so many different kinds of medications that can be given for pain. These are just oral medications. Again, we talked about a lot of the different topical medications, but we didn't talk about all these interventions. There's so many other kinds of nerve blocks and injections and special kinds of infusions that they can give to help with pain. And then there's all these other kinds of integrated modalities and other kinds of therapies like massage or low-level laser or acupuncture or phonophoresis. So just so many different options really that we have available to try helping with pain. So I would just say that, if this is something that you're dealing with, definitely work with your providers because there are many, many different things that can be tried. So again, if you are having uncontrolled pain, it may be helpful to see a specialist, and these are some of the different specialists that may be helpful to see. So you could always ask to see a supportive care medicine or palliative care medicine physician. You could request to see pain management or an interventional pain management team. The difference between these two, sometimes they're kind of intertwined, but interventional pain teams will usually do more procedures like nerve blocks or certain kinds of injections. And then, my background, physical medicine rehabilitation, sometimes we can be helpful too, especially if the pain seems to be coming more from like a muscle or joint type of source. All right, so that's it for pain. And now for the latter part of our session, I want to generally go over fatigue, which again is really, really common. And we see how common it is right here, actually. So for people who are going through treatment in cancer, fatigue is almost universal, basically affecting almost everyone. And it's not uncommon that it continues to affect a lot of people after they have finished treatment. So this is just something that we see very, very commonly. And this is a different kind of fatigue. So we call it cancer-related fatigue, and it's different from normal fatigue because in normal fatigue, it's usually going to be related to kind of how much you've been working, how busy you've been, how active you've been. And usually, if you've had a really rough day, really long day, if you go to take a nap or you go to bed that night, you should wake up in the morning feeling refreshed. But cancer-related fatigue is not like that. It's not proportional to how active we've been. If you take a nap or you go to sleep, it's not, they still feel tired, when you wake up. And it can be persistent and severe to the point where it can interfere with everyday activities. And there's a lot of different contributing factors and causes of cancer-related fatigue, and a lot of them are listed here. And I kind of made this one the biggest. But one of the contributing factors is cytokines. So what are cytokines? So cytokines are basically they're little kind of messenger molecules that cells secrete to basically communicate to other cells. So cells secrete cytokines. And the cytokines will go talk to other cells and make those cells do something, basically. And when somebody has a tumor, some of the cells in the tumor can secrete cytokines, and some of these cytokines essentially can lead to kind of a low level of inflammation throughout the body, and to a degree that can also affect the brain. And this is one of the reasons why we think that cytokines and cancer specifically can cause this kind of fatigue. But there are also, kind of all these other factors that we talked about too. So some of these things we can kind of treat and help, and other things we can't. But, for the purposes of alleviating fatigue, we want to focus on, the ones that we can treat and the ones that we can affect. So the things that we can kind of help are side effects of cancer treatment, pain, emotional distress, anemia, or when your kind of blood levels are low, specifically your hemoglobin, nutritional deficits, anybody using alcohol or substances, medications, sleep disturbance, and your level of activity. So these are all things that we can modify to some extent. And when we optimize these different factors, we often see benefits with people's energy levels and how much fatigue they're experiencing. So kind of for the remainder of the talk, we're going to go through each of these. So one of the easiest things that we can really do is by adjusting medications. So polypharmacy is the use of four more medications, and it's really, really common if you're undergoing treatment for cancer. And a lot of the medications that we give to people going through cancer treatment can lead to people feeling more sedated and more tired. So these include like opioid medications or medications for anxiety, like Xanax or Ativan. Muscle relaxants can oftentimes cause sedation. A lot of those nerve pain medications can cause sedation. Anti-nausea medications can cause sedation. And antihistamines can often cause sedation. So when this is the case, it's really simple. We always want to go with the lowest possible dose because the less you take, the less side effects that'll occur. And if you can ever get rid of any of these medications because maybe it's just not needed or it's not helping, then that's always something you want to do. And then timing is really important to consider. So if medication, it makes you more tired, then, if you're able to, you might want to consider taking that medication at night, of course, after discussing with your medical team. But that is something that can sometimes just mitigate fatigue really quickly. Physical activity and exercise is another thing that has been shown to be extremely beneficial for people dealing with fatigue. And you see the word category 1 here. And what this means is that a group with the National Comprehensive Cancer Network was tasked with basically finding out all the best ways to treat fatigue in cancer. And they came up a list of all of the available therapies of dealing with fatigue. And everything that they labeled as category 1 means that panel, there was uniform consensus. So everybody on the panel agreed among a panel of experts that this is a very helpful thing. And it also means that it was supported by lots of good quality evidence. So this is something that can be really helpful. And one thing I will state is that it doesn't have to be like a tremendous amount of exercise. I'm going to tell you what kind of their specific exercise recommendations are. And it's kind of a lot, but every little bit you do counts. So don't think that you have to turn into like an exercise guru or, turn into like the most fit person ever. You really don't. It's like, 5 minutes, 10 minutes, just a few minutes, whatever you can do and getting started somewhere can be helpful. So, if you are not getting like any activity right now, then I would encourage you every little bit counts and to get started with even the smallest amount that you can. Honestly, even if it's 1 minute, then do 1 minute. Okay, so these are the actual recommendations from the American College of Sports Medicine. And I said it was a lot because it's just a lot. So they recommend 150 minutes per week of moderate intensity aerobic activity and 2 to 3 days per week of strength training in order to kind of get a lot of these benefits. But again, start wherever you are, do as much as you can or do as little as you can. But I would say, the most important thing is just to be consistent. And we can see here that the more you exercise, there's really strong evidence that it helps with fatigue. But there are additional benefits of exercise, including that it can help with anxiety, depression. There's also some information that can help with lymphedema, as well as bone health and sleep quality. Okay. So other things that we can do are there's various psychosocial interventions. So again, this is a category 1 recommendation. Psychosocial interventions are going to be things like journaling or joining a support group or like undergoing counseling. Massage can be helpful for some people. Again, this will depend on if you have like bone metastasis or if you have like low platelets or something. So if you're on active therapy and you maybe have some of these issues, you might want to consult with your physician before undergoing this particular therapy. Energy conservation techniques are basically the idea that you have, a finite amount of energy per day. So you want to do all the things that you know you have to do, prioritizing the things that you have to do, and then the things that you don't have to do, you will put off to a later time. Acupuncture can be recommended in the post-treatment setting, and this has also been shown to be helpful for fatigue. Bright white light therapy is basically exactly what it sounds like, where you just get a really, really bright light and you kind of wake up in the morning, you sit in front of it and let it shine on you for like 30 to 90 minutes. I suppose the sun would do the same thing as long as you're wearing sunscreen, but this is thought to kind of reset your circadian rhythm. And then sleep optimization. So sleep optimization is really, really important. So I'm going to talk about this in a little bit more detail. So people going through cancer diagnosis have a lot of trouble with sleep, reported as 30 to 75%. And people may have trouble sleeping for a variety of different reasons. This is not a comprehensive list. But if you are having trouble sleeping, it is important to get to the root cause of it and to address that root cause, because it's really, really important to get good sleep. So one of the things that might be occurring is you might have bad hygiene. Bad sleep hygiene would look like if you take a lot of daytime naps, if you have any caffeine or alcohol before bed, if you use your computer or cell phone before bed, or even worse, if you use them in bed, doing any kind of stimulating activity like watching TV prior to sleeping, or having a poor sleep environment, like with having like a lot of ambient noise or like a lot of ambient sound. So these are bad sleep hygiene habits, and we would want to replace them with productive ones. And that's going to be things like having a really dark and quiet room and doing stress reducing activities like yoga, meditation, journaling, or reading prior to bedtime. So something that's really, really grown in popularity in recent years for people having difficulty sleeping is something called cognitive-based therapy, or cognitive behavioral therapy. And basically, this is a kind of therapy that identifies the maladaptive habits in somebody's sleep routine and replaces them with adaptive ones. And there are a lot of different resources for undergoing this kind of treatment. And a lot of these are actually free. So if you are getting treatment at Cedars-Sinai, we actually have a class called Sleep Skills class, which can kind of teach you these different techniques. But if you're not, there's a ton of other applications. I don't believe this one is publicly available anymore, Sleepio, but CBTI Coach is free and it's available on App Store. So you can just literally download this. It's not the most user-friendly, so it's kind of more difficult to use. But for some people, it can be effective. And there's quite a bit of research showing that's effective. One that I'm recommending more and more these days is an application called Go to Sleep. And this is through the Cleveland Clinic. So if you literally just Google Go to Sleep or go to this website, you can actually buy kind of their course. It's like a 6-week long thing. It's $40. But for some people, it can definitely be helpful. And then in situations where these non-medication strategies are not working, then there are always medications and supplements. So the one that you probably hear most commonly about is melatonin, which is available over the counter. If you want to try it, I would recommend starting at 1 to 5 milligrams. However, the evidence that this is helpful is not the best, so it's not always recommended. It's really shown to be more helpful if you are a shift worker or if you are dealing with jet lag. But more commonly, given medications for sleep will be things like trazodone or Remeron, which are both antidepressants, as well as benzodiazepines like lorazepam or diazepam. So with that, I thank you for your attention, and I'd be happy to discuss any further questions if anybody has any. And if you don't want to ask here, feel free to send me an email, and I'll get back to you when I'm able to, usually like 24 to 48 hours. But yeah, be happy to take any questions.
All right, ladies and gentlemen, did we ask all of our questions? I see something.
Yeah, thank you so much for joining.
Yeah, this was excellent information. Even in connection with our sleep talk last month. Um, this is I can't wait to put all this together. There's so many people that were texting me saying, I have a funeral, I have a this, I have a that today, but are you recording? So this is really going to be a blessing, even for those who were not able to make it today. Um, so Miss Etta, did you have a question?
No, but he hit on so many things that I'm kind of dealing with, and it was so informative. And I was, well, not screenshotting, but I don't know, old people in technology, but it was so much good information, and I feel a little better about some things.
Amen.
Glad to hear that.
Amen. For me personally, like, so I asked the question about is it too late? There's so many things that we don't know we need to ask about or be concerned about. We think it just goes with the territory. And that's whether you have cancer or any other ailment. We just say, oh, it's old age, or we're aging, or this is just new, or this will go away. But to find that we should not let painful things continue. We should not let them, wait till they go away. But at least inquire with your physician to see if this is something that could be temporary. Or, I mean, how long do we want to suffer with the pain? And it's amazing that while we don't want to, and we mumble to ourselves, we still don't mumble to our doctors. So this is I don't think I'm going to tolerate much more uncomfortableness in my body without inquiring to see if there's something that can be done. Because we always talk about how we should take medication ahead of the pain. Now, we know that when we have surgery, we know that if we're going to the dentist. But if you don't know that what this is, there's somebody. We just ought to ask them. So this was great.